Our final speaker is Dr. Ruenreong Leelanukrom. His topic is Challenging the Dogma, Transfusion Strategies.
Good morning, all ladies and gentlemen. First of all, I would like to thank the organizing committee for inviting me to join this Congress to the beautiful city of Mumbai. I came from Bangkok, which is about 3.5-hour flight from on the east side of Bangkok. Last year, this is a very the year that all Thai people never forget in all their own life, because we lost our beloved King Rama IX. And this is the hospital, King Chulalongkorn Memory Hospital, where I came from. Transfusion of allergenic red blood cell is the essential part in patient care during anesthesia and surgery. However, transfusion is not without risk. The serious hazard of transfusion scheme estimated that 1 in 99,000 blood component issue, there's some death, which was hemolysis, transfusion-related circulatory overload, delayed transfusion, and acute transfusion reaction. So why do we need transfusion? The ultimate goal of red blood cell transfusion is to improve oxygenation by increased oxygen carrying capacity. Many guidelines has been developed, including in children. Most transfusion trigger was between 7 or 6 or 8 or 9. And so what is the number? But roughly it's between 6 to 7, and the goal may be 9 or 10 grams per deciliters. It depends on what strategy we use, maybe restricted or liberal strategy. But the reason behind of this number is to improve oxygenation by increased oxygen carrying capacity, and the balance is between tissue oxygenation and tissue oxygen consumption is very important concept. So I would like to talk about the tissue oxygenation. Tissue oxygenation is the cascade from oxygen delivery to the tissue, which depend on this cardiac output and arterial oxygen content, and then downflow to the blood flow to organs, and finally to the tissue microcirculation and extraction ratio, oxygen extraction ratio, which is different between tissue. The oxygen delivery is the product between cardiac output and arterial oxygen content, which depend on the oxygen binding with hemoglobin and dissolved oxygen in the plasma. So there's the interdependence between the heart, the lung, and the blood, hemoglobin concentration, oxygen saturation, and heart function. Any disturbance of these components can cause hypoxia, which decrease in hemoglobin concentration we can call it anemic hypoxia, and the lungs can be hypoxic hypoxia, and the heart can be stagnant hypoxia. So this slide summarizes the concept of oxygen delivery, arterial oxygen content, and the cardiac output. In normal humans, there are a wide range of reserve of oxygen delivery. In this scenario 1, in the adult patients, the hemoglobin level of 15 grams per deciliters and the oxygen saturation is 99, cardiac output is 5 liters per minute. We can get 1,000 ml per minute of oxygen delivery, and the oxygen consumption is roughly about 200 to 300 ml per minute. The oxygen delivery is higher than oxygen consumption to 4 folds, and the oxygen extraction ratio was about 20 to 30%, which we have much research for this. In the scenario 2, where the hemoglobin level was dropped to 10 grams per deciliter, with about 1/3 drop, and the oxygen consumption saturation is actually the same, and cardiac output is 5 liters per minute. which is not normally exist in normal condition because cardiac output will begin to rise. And the oxygen consumption is about 688 ml per minute, which is decreased in 33%. But oxygen consumption is actually the same. We have still two-fold in excess of oxygen consumption, and the tissue have increased oxygen extraction ratio to about 30 to 50%. There are biphasic relationship between oxygen delivery and oxygen consumption. In this phase, the demonstrated the reserve in oxygen delivery as compared to oxygen consumption. When the oxygen delivery is dropped to a critical level, the oxygen consumption will tend to decrease. That means that tissue hypoxia or anaerobic metabolism will start. We call this portion is supply dependent portion, and this portion is oxygen delivery or oxygen supply independent portion. In some situations, this curve may shift to the right. That means oxygen critical level of oxygen delivery will happens earlier than this, such as in sepsis or ARDS situation. So the ultimate goal of red blood cell transfusion is to increase oxygen delivery before these critical levels was reached to prevent tissue hypoxia or anaerobic metabolism. In adults, this number was approximately about 300 to 350 mL per minute per square meters. This is a study in children that's normal volemic hemodilution during surgery. The hemoglobin was dropped down to 3 grams per deciliters. The oxygen delivery was dropped from 500 to 260, but the oxygen consumption was maintained. This is another study in normal volemic hemodilution in young children. The hemoglobin was dropped down to 17, but the oxygen consumption can be maintained with this level of hematocrit. This is another one study that the lactate level was maintained, but the venous oxygen saturation was dropped, where the hematocrit dropped down to about 12 to 14%. There's some factor influencing oxygen delivery, basal metabolic rate in some organ and tissue which has varying level of oxygen critical levels and disease state, as I already mentioned, such as sepsis and some patients such as pediatric patients, which is everybody knows that oxygen consumption was higher than in adult. So apart from oxygen reserve, there's some adaptation to anemia in humans. There's at the global levels, there are increase in cardiac output, but there is no consensus or nobody knows what the actually levels of hemoglobin that cardiac output begin to rise, and there's some compensation was the redistribution of organ blood flow, which is this depend on the activities of increased sympathetic system activities, and which sometimes may be impaired during anesthesia, may be influence of anesthetic agents, and also in the children, as Professor Cote already mentioned, the cardiac output in children and stroke volume response in children may be different than in adults. At the tissue levels, there are increased tissue blood flow from the effect of decreased blood viscosity, and also there's increased ridership of oxygen or hemoglobin dissociation curve, and the oxygen extraction ratio is increased. The oxygen extraction ratio in normal at the global level, at the whole body, is about 20 to 30%. But in myocardium, which has a high metabolic activities, the extraction ratio is very high. This makes that myocardium is more susceptible to ischemia. So transfusion is needed to be started before the extraction ratio of 50 to 60% was reached. So this slide summarizes the adaptation to anemia, change in cardiac output, redistribution of blood from non-vital organ to vital organ, and change in oxygen extraction ratio, shift of hemoglobin dissociation curve to the right. So the transfusion strategy is to balance between the oxygen delivery and oxygen demand. This slide shows the change in oxygen demand, which is imply that tissue hypoxia can occur more earlier than we think. So there's two approaches for transfusion. First is we start with the hemoglobin level where we should start transfusion, or we can use another one new concept of physiologic transfusion triggers. Is we can measure the parameters of at the global level, lactate level, mixed venous oxygen levels, decreased oxygen consumption, which means tissue hypoxia has already been developed, and extraction ratio, all measured at the regional as myocardial ischemia, such as ST segment changes by transesophageal echocardiography or brain oxygenation. So what about us? There's different physiology in children, different of, especially in newborns. Hemoglobin was changed, oxygen dissociation curve was changed, cardiovascular function and compensation is different, change in oxygen consumption, physiology is changed, and finally, last but not least, estimation of blood losses, particularly in newborns in massive transfusion disease, may be difficult and maybe depends on the experiences of the anesthesiologist. So, what should we think about? Firstly, we have to maintain normal volemia. Normal hypovolemia is poorly tolerated. So before we start transfusion in acute blood loss situation, we can start with crystalloid, either crystalloid or colloid, whatever your philosophy is, and then you think about the tissue oxygen delivery and oxygen consumption, and maybe you can set some level of hemoglobin, what you think, but you have to think about these factors can affect the hemoglobin or the threshold that we think about, and we have to monitoring side of inadequate tissue oxygenations at the global level or either at the tissue level. Thank you for your attention.